Yay! Hi, I'm so happy that you're here. Welcome to my modules on how to support your client through an induction. This is hopefully going to be a helpful tool for you to learn more about inductions and the medications offered, and just kind of like build a foundation of knowledge around inductions, and that will help you as you support your clients, but it will also help you to better prepare your clients for an induction themselves. So I hope that you learn a lot. A little about me. I am Sarah Osborne. I have been a full-time birth doula since 2008. I have supported about 900 families as a primary doula in that time. I am married. I have 3 kids and 3 cats. I live in Tacoma, Washington, which is just about 40 minutes south of Seattle. I absolutely love coffee, like a lot, and that's such a Seattle-like thing to say, but it's true. I love cats, I love Disney, I love birth, I love babies, I love music. So that's just kind of a little about me. If you know the Enneagram at all, I am a 2 wing 3. And aside from being a birth doula, I am also a birth photographer, newborn photographer. I'm also a childbirth educator and a doula mentor and coach. And I don't work as a solo doula anymore. I actually helped form the Birth Collective, PNW, for Pacific Northwest about 5 years ago. So now I am in a partnership with 2 other doulas, and we have a very busy, wonderful birth practice. So there's a little about me, and with that, we can get started. So your client needs to be induced. Now what? Inductions happen for a variety of reasons. They could be medically indicated, it could be an elective induction or like a patient preference. It could be due to a health condition or a placental issue or an issue with baby. There's just so many reasons. But once your client has this talk of induction that is coming up, here's what you can do as the doula. First, ask her, how does she feel about this induction? Don't just project your feelings or your opinions on this induction. Like, really, truly ask her how she feels, gather all of that information on what she's thinking, how she's feeling, what she's worried about, what she's concerned about, all of those things. And then I would ask her if she would like more information. And maybe she wants more information on inductions in general, or maybe she wants more information surrounding like the reason that she needs to be induced. Maybe she would like help from you in formulating some questions that she can ask her care provider so that she can get the answers directly from her provider, or a host of those things. All of that information gathering will help her make a good decision for herself. I would also ask her, how can you as her doula best support her? She might not have an answer to that, and that's okay, but I would ask her, and if she doesn't know, follow up in a day or 2 and tell her to think about it, because you might be surprised at what she tells you. In the US, about 1 in every 3 births is an induction, which is a crazy high number. And so if you are working in the birth world, you for sure will encounter inductions, probably more than you would like to. Remember, you are not there to save her from this induction. You are not there to try and prevent it or sway her. She needs you now more than ever. She wants to know that you support her no matter what her choices are, and that you are in her corner and you're not judging her. Keep your personal opinions and biases to yourself and show her the unconditional love and support that she deserves. She needs you, and she is so lucky to have you. I don't know if you've heard of a bishop score before, but this is something that pretty much every provider calculates before proceeding with an induction. Sometimes they're really open and upfront and talk to the client about this, and sometimes they don't mention it at all, and your client has no idea that this is a thing. So I would educate the client on this. Basically, when your provider does a cervical exam, they are giving a point or like scoring system to each of these things in this category of cervical positioning, cervical consistency, how thin or effaced your cervix is, how much dilated it is, and the baby's station or how low the baby is in the pelvis. So based off of the answers for all of those things, they're going to give it a point system. And in fact, there's a different bishop score calculator that you can find on Google that I would recommend you go find. And it actually will take the point system for this and it turns it into a percentage. And that percentage is going to kind of tell you, based off your bishop score, how likely, percentage-wise, is this induction going to end in a vaginal birth or a C-section. And I think that that is really helpful for you as the doula to know, but also as a parent, I personally would want to know that. So I think this is good information that you could share with your client to help them make decisions and just so that they have more knowledge about what's happening and why. So cervical position, if you look at that top picture, that shows us a cervix that is pointing posterior, which is like towards your butt, and that is where it starts. And then slowly, the end of pregnancy or in early labor, it's going to move forward to an anterior cervix, and that is like facing out your vagina. It doesn't usually do that in like one big motion. It slowly moves forward, and so it might like stop in the middle, and that would be a midline placenta. I mean, a midline cervix, and then it will keep going to anterior. So your cervix actually moves forward in your body, and then the consistency of it matters as well. So a hard or firm cervix is going to be about as firm as your forehead. A medium soft cervix is about as soft as the tip of your nose. A soft cervix is about as soft as your lips. So that's a huge change in consistency. It's going from forehead hard to as soft as your lips. Hugely different. It also is going to thin, which is called effacement, and that is told in percentages. So a normal cervix, like not in labor or not pregnant, let's say, is about 2 inches thick or long. And so that would be 0% effaced. It hasn't thinned at all. If it's 50%, that's about 1 inch thick. And it's going to get 100% thin, which is literally about as thin as a sheet of paper, which is insane. So then that all kind of has to happen, or the majority of that has to happen before your cervix starts to dilate. And that is what everybody thinks about and talks about, is how many centimeters are you? And they know that when you get to 10, you can start pushing. And that's really all parents are thinking about. They're like, okay, I'm going to check in. They're going to put me into labor, start contractions. I'm going to get to 10 centimeters, push the baby out. They don't usually know all these other things that need to happen before dilation. They don't know about the cervix moving forward. They don't know about it going from forehead hard to lip soft. They don't know that has to go from 2 inches thick to paper thin. They don't know that that needs to be mostly done before it can start opening. So that is really good, important education, especially going into an induction. baby station, they will also give that a point system, and that's just how low into the pelvis baby's head is. So the minus numbers are like a floating or a very high up baby. When the baby is engaged, that's 0 station, where their head, they're kind of right here is like at the ischial spines. And then once that baby's going lower below the pelvis, trying to see how you can see my hands, low below the pelvis into the vagina, that's like the plus numbers. So +3, +4 is like crowning. We can see your baby's head on the outside. Okay. Good information to know. Okay, so my analogy is I am going to equate a cervix to a cube of butter. So if your cervix is thick and is hard, like it's forehead hard and it hasn't thinned very much, that is like kind of like a frozen cube of butter. Now, if you have a frozen cube of butter and you try to stick your finger through that and make a hole, which would be an opening or like a dilation, how easy is that going to be? Not easy. It is not going to be easy to stick your finger through a frozen cube of butter. When you've had butter sitting out on the counter for an hour or two, you can kind of get your finger in there. It's not easy, but it's not as hard as a frozen stick of butter, but it's not going to make a huge difference. That's kind of that middle picture. What we want is a buttery, soft, melty cervix, like it's been sitting out on the counter all day in 90-degree weather. You could very easily stick your finger right through that. That is where we want your cervix to be before we start contractions, because contractions are going to happen no matter what. If we give you Pitocin or if we give you medication to start contractions, your uterus is going to contract. But is that cervix going to respond to those contractions if it's a frozen stick of butter? No, it's not. And then you're having contractions and your cervix is doing nothing. We don't want that. If your cervix is nice and soft and buttery, then we can start contractions and it's going to respond and it's going to open and dilate. So that is a really good analogy to explain to your client on it's not just about starting contractions. There's this huge first step of an induction that's called cervical ripening. And that is the key to a successful induction. We need to ripen that cervix, get it from frozen butter to melty soft butter before we start contraction medication. Then your cervix will respond and your induction is likely to be much more successful, ending in a vaginal birth. A lot of providers want to rush that stage, not be patient. And sometimes parents don't want to be patient for that either, because usually they're not mentally prepared or given the education that this cervical ripening stage could easily last 12, 24, 36 hours. That is not uncommon, and especially with a first baby. So we want to plan a full day of cervical ripening where you're checked in and really not much is happening. You're not in labor. You're not having a baby. You're just there chilling and waiting around, which is mentally hard. So, okay, we're going to end this little first module right here. And then when we come back for module 2, we're going to talk about cervical ripening medications like Cervidil and Cytotec and Laminera sticks and all of that stuff. So, okay, I will see you on video 2.